So with the topic this vague, I had license to be impressionistic, so be prepared. I think we're good? So we'll talk about P53 mutated deletion 17 PCLL, or when the good cancer isn't. And so I thought that in the interest of time, we would just I would just summarize here briefly. You can see if you click up right there on the right, you can learn more, and that'll answer all the questions that we have about treating deletion 17 PCLL in 2014, or not. So let's take it through a series of cases that we've seen recently at OSU, not so much to make recommendations necessarily for management, but to discuss some of the issues that are raised by the availability of ibrutinib and some of the other drugs coming down the line. So the first case is a patient that we routinely see that as risk stratification becomes more routinely applied in community practice, patients who are identified as high risk with early stage asymptomatic CLL are referred to us to ask whether or not they should be treated, whether or not early intervention is warranted given results of some of the newer drugs. And this is a patient exactly in that situation who was referred by his doctor to decide whether or not ibrutinib treatment was appropriate as early intervention. And the reason that everyone is interested, of course, is for these things that we already know, the characteristic cytogenetic hierarchy that's very well established in clinical practice. And we know that mutations in P53 convey the same risk independent of deletion 17p status. But we do know that all deletion 17p patients are not the same. And in this series of patients from MD Anderson in the Mayo Clinic, they established that patients who have no other risk factor, and in this study, the other risk factors were mutational status of the IGHV, as well as RY stage. But patients who had RY stage 0 mutated CLL were actually 100% progression-free at 3 years. So not all deletion 17p patients necessarily progress rapidly, and it must be understood in the larger context. But still, there's no convincing evidence that early intervention with any strategy, including ibrutinib, is yet warranted. This is one study that's going to hopefully help answer that question, the CLL12 trial of the German CLL study group, which will randomize patients who are risk stratified by a number of features into low, high, very high, and intermediate risk groups. And the patients who are anything other than low risk will be randomized to early intervention with ibrutinib or observation. And this study is underway, and results are going to be interesting for all of us as it potentially changes practice. So a more typical case is this one. This is that same 55-year-old man, but now he's about 18 months into his course with CLL. He has now RY stage 3 disease. He's progressed to require treatment. And while he hadn't undergone risk stratification at the time of his diagnosis, he's now had a bone marrow biopsy to work up his cytopenias. They show progressive CLL, and they also identify deletion 17p on FISH. So his doctor has been very interested to give him FCR, since he knows that unequivocally is recommended as the standard of care for frontline therapy of CLL. And so he is concerned, however, that the patient may require additional therapy beyond induction, and so he follows NCCN recommendations and refers him to a tertiary care for consultation. And so there's no place easier to make a treatment decision than by following the NCCN algorithms, which are completely transparent and easily translated into routine clinical practice. And so I think for deletion 17p CLL, I think many clinicians in the community get to the stop sign, and that's about as far as they get. And they immediately punt to centers like the ones where we all come from. And that's probably appropriate. And so basically, induction followed by consideration for allogeneic stem cell transplant is in fit eligible patients remains the NCCN frontline recommendation. But when you look more specifically at the suggested treatment regimens in the NCCN criteria, NCCN guidelines, you can see that they run the gamut from FR immunotherapy approaches with alemtuzumab and rituximab to even obinutuzumab and chlorambucil, which may be appropriate in an elderly, less fit patient. We won't even look at that list for second-line therapy, which is really all over the map. But if you summarize the results of some of the more pertinent therapies as are here, you can see that the highest rates that have been convincingly reported have been, and consistently reported, have been with alemtuzumab-containing combinations, particularly the CLL-20 trial of the German CLL study group of alemtuzumab and dexamethasone, followed by consolidation with transplant or further alemtuzumab, and the CFAR group that was treated at MD Anderson. And you can see overall response rates are relatively high. CR rates are respectable compared to standard fludarabine-based chemoimmunotherapy. And the median progression-free survival is not too bad at about 3 years. But then there are studies like this one that begin to call into question whether or not a 3-year durable remission is really adequate anymore. And so we've already seen these results, and I won't go through it in depth, only to say that when the survival curves or survival lines, it changes your perspective. And so there will be increasing pressure on all of us, driven, I think, in part by some of our community practicing colleagues, to move ibrutinib up very quickly into the front line for patients with genetically high-risk disease. Idelalisib and rituximab, the results that Susan O'Brien presented last year at ASCO, represent another very viable alternative with all 9 of the genetically high-risk patients with a 17p or p53 abnormality responding. So a very different world and a phenomenally different toxicity profile as compared to alemtuzumab-based combinations. Again, very impressive progression-free survival at 24 months with further updates, hopefully to better clarify the duration of response. And this, again, while this includes patients who were previously treated, this was a curve from not last year's ASH, but the year before, but is interesting for just looking at how ibrutinib and rituximab for deletion 17p really does appear to be changing the natural history. And there are several other curves that we could show like this, and we'll finish up with one at the very end. So then what becomes of transplant? And so this is a recent landmark analysis, a 3-month landmark analysis that was based in Europe, recommending transplant according to the EBMT criteria for CLL. And the first curve on the left just segregates patients by the availability of a donor. And here the availability of a donor is tied to improved survival. And on the right, you can see that the reason for that, the very top curve, is that patients who had available donors were more likely to go on to transplant. So it does appear that survival can be improved with allogeneic stem cell transplant consolidation following some sort of induction. But if you look for what the progression-free and overall survival are in historical cohorts of allogeneic stem cell transplants for high-risk CLL, you can see that the 3-year progression-free and overall survival are about 40–45%. And so when we look back at where our estimated progression-free survival is on some of these other curves at 36 months, we have to start questioning again whether or not the standard algorithm for consolidation with transplant is really still the correct one. And I'll just remind you of this slide that Jennifer Woyak presented yesterday. And as we've looked through at our historical experience with now more than 300 patients treated at OSU with ibrutinib, we can see that patients with deletion 17p CLL are, for large part, remaining on therapy. and that the most important consideration, genetic consideration, in predicting discontinuation of ibrutinib is cytogenetic complexity, which of course is a time and treatment emergent phenomenon in patients with CLL, which suggests again that earlier use of ibrutinib could be advantageous. So what about this case here? So this is another sort of case that we're beginning to see. This is a patient who achieved a remission, is in remission now after treatment with FCR for deletion 17p CLL, and had a bit of minimal residual disease when he was restaged following his initial therapy. And his doctor has recommended surveillance. Actually, his doctor's probably recommended rituximab maintenance, but we won't talk about that. But so his doctor recommends surveillance, because we're scientists here. And he's now coming to you because he's heard that eradication of minimal residual disease is a worthy goal in treating CLL. And while he's read about transplant and he's excited about T-cell directed therapies, he's not able to travel. He's not interested in the risks associated with transplant. And he wants to know whether he should start ibrutinib even though he's a year out from finishing therapy. So I'll just remind everyone that the last time we undertook treating patients in remission with another drug, it was with alemtuzumab. And 4 or 5 years ago, there was collective enthusiasm for alemtuzumab consolidation after fludarabine-based chemoimmunotherapy. And there's very limited data from a German CLL study group trial of alemtuzumab consolidation that suggested that there was a progression-free survival advantage, although that was based on a vanishingly small number of patients in a trial that was discontinued early because of excess toxicity. So this is just reviewing alemtuzumab consolidation after fludarabine or fludarabine and rituximab from the CALGB Now Alliance. And really what we found is that the survival experience of the patients with deletion 17p and 11q CLL was not significantly changed with the addition of alemtuzumab. And there were, of course, deaths from complications of infection in those patients. So these are the results of giving ibrutinib to patients in remission as consolidation therapy. They don't yet exist, but rest assured there is a multi-center Medicare-sponsored clinical trial undergoing at thousands of community sites across the country, the results of which are eagerly awaited. All right, I'll take one final case. This one now is a patient who is more typical for the CLL patients that we see. So a patient with CLL that was treated with BR, she achieved a relatively good remission, and now she's relapsing about 24 months after her treatment, and her repeat cytogenetics demonstrate emergence of a 17p clone, and her doctor's referring her now because when he's managed relapse 17p CLL in the past, it just hasn't gone very well. So he's wondering what she should do. Complicating matters is that she's now coming to you 2 weeks after hospitalization for a bilateral pulmonary embolus, and she's anticoagulated with warfarin. So what do you do? So I'll just remind everyone that this is a place where idelalisib may really have a very clear advantage over ibrutinib, since there are no emergent bleeding considerations in patients treated with idelalisib thus far, with pretty durable results in the relapse setting. But these results are still pretty profound. And I think we're all eagerly looking forward to the results of the RESONANCE study, which in addition to providing phase 3 data for efficacy, will also provide some very important data about toxicity from ibrutinib as compared to alternatives, including the bleeding risk. And so I'll just finish that It's going to become increasingly difficult to imagine the patient with relapsed deletion 17 PCLL who shouldn't receive ibrutinib. And part of the reason is because of results like this. And this is sort of a historical cohort analysis from patients treated at Ohio State on successive generations of therapy that's now been published by Deb Stevens, who's one of our graduating fellows. And as you can see, really ibrutinib is changing the natural history of patients with deletion 17 PCLL very impressively. And while I remain a cyclin-dependent kinase inhibitor enthusiast, I can't argue with the curves in front of me. And so I think we have a lot to learn about inserting ibrutinib into our clinical treatment paradigms, but it's certainly going to change what we do going forward. And that was it.